My name is David Jones. I'm on the faculty here at the Department of Global Health and Social Medicine at Harvard Medical School and the Faculty of History of Science and the Faculty of Arts and Sciences. It's my real pleasure to welcome everyone today on this beautiful spring afternoon. I wish we could hold this lecture outside, but I don't think the sound would work well. But to this lecture today by Professor Charles Rosenberg, offering a historian's perspective on the placebo event. My co-hosts for this event are Scott Podolsky for the Center for the History of Medicine at Countway Library and Ted Kapchuk in the back from the Program on Placebo Studies and the Therapeutic Encounter at Beth Israel Deaconess Medical Center. Now, this is the fourth in a series of events funded by the Robert Wood Johnson Foundation in conjunction with the Center for the Program on Placebo Studies that Ted has organized over the past year or so. The first event was last June on the science of placebos. There was an event in December on the use of placebos in clinical medicine, one in February about religion, ritual, and placebos, this one today, and then the fifth in this series will take place next fall on behavioral economics and the placebo effect. And so if you're interested, keep your eyes open for announcements about that event as planning develops. Now, as I listened to these first three seminars that Ted had organized about the science, the clinical medicine, and the religious questions about placebos, listening to these as a historian of medicine, I was intrigued by what I was hearing. Physicians and historians of medicine have traditionally been dismissive of past therapeutic practices, and there's certainly many things that doctors have done to patients in the past, which have given many people a good laugh as we look at them now from the perspective of modern medicine. You know, why did bloodletting work? Often they will say it must have been a placebo effect. So the tendency has been to dismiss the actual efficacy of these interventions and just invoke this vague notion of the placebo effect. But as I was listening to these talks by people who have been doing serious research on placebo effects, I realized that that kind of impoverished view of the history of past interventions misunderstands both placebos and the efficacy of past therapeutics. And so I convinced Ted to co-organize this event today, looking specifically at this question of placebo effects and the history of medicine. And for a talk on history and placebos, there is, of course, no better person to give this talk than Charles Rosenberg. He's long been the preeminent historian of medicine in the United States with a long career, first at the University of Pennsylvania, and then for the past almost 15 years here at Harvard University. He's published crucial work on the history of epidemics, on mental health, on hospitals, and on many other topics too numerous to review here. But his particular expertise for today's talk traces back to a paper he wrote in 1977 on the therapeutic revolution. Now, he makes many arguments in that paper, but one is particularly relevant, and that is that doctors and historians who dismissed past therapeutics misunderstand two important points. First, that treatments did work. They provided relief to patients, and they were actively sought by both patients and doctors. So no matter how silly these treatments must seem, they were doing something that was valued by the people who were involved. And it's important for historians to take this seriously and try to understand how this happened and what was going on, why these things that we would dismiss were seen as so valuable for thousands of years. And then the second point was that the placebo effect was not the right explanation. These were not inert substances that were not given deceptively. Something else is going on. And so from those two basic observations, he launched a fascinating discussion about the nature of the therapeutic encounter and the meaning of efficacy in medicine and in other kinds of therapeutic practice. Now, in the intervening years since 1977, our understanding of both therapeutics and the history of medicine have changed substantially. And this seemed like an opportune time to invite Charles back to reflect on placebo effects and offer his historian's perspective. Thank you.
I could start over. Maybe like a rewarm beans or something. Started in 76. Okay. This paper, in some sense, started when I volunteered to give a talk on the history of therapeutics in a conference for the bicentennial. And I had never known what to make of traditional therapeutics, because how do you make sense out of a system that seemed to work for such a long time, in which the standard sort of interventions were so severe in the sense of bleeding, heavy metals, blistering, the kind of things that doctors kind of made fun of in 20th century doctors. And the more I thought about it, the more I decided that the system did work, and it worked partially because, or largely I thought, because the patient and doctor shared a certain set of assumptions about what was going on, that the body was out of whack when it was sick. It needed to be brought back into balance, and if you produced lots of urine or diarrhea or blood, you were showing that you were intervening and changing the balance. And without seeming too facile, there was a sense of performance and transaction and ritual, that everyone could witness this interaction. And in fact, doctors use the word exhibit for prescribe as a symptom. I mean, as a synonym, rather. So that there was this notion that you were exhibiting a physiological impact. Now, that struck me as very revealing in that it made me start thinking about efficacy in a way that was not understood, accepted, and I think still, as David implied, is not standard. In other words, when we look back at, and most of the people in Longwood, when they look back at medicine of 1800, 1850, they wonder that anyone survived, or it seems like a lot of placebo effects or placebo activities, if you want to, maybe not the right word. And I just want to read a quote from, oh, okay. Please, if I start going up and down or not clear, just wave your hand or show that you're restless. I want to read a quote from a paper by Arthur and Elaine Shapiro, who were the kind of doyens of placebo studies for decades. This is from the 90s. We propose that the available data support the somewhat startling hypothesis that the history of medical treatment until recently is largely the history of the placebo effect. And then another quote from them a little later. Each decade in the second half of the 20th century resulted in an accelerated increase of specific non-placebo treatment, with a veritable therapeutic revolution by the end of the century, but alas, no end to the placebo effect. And I think that is a very revealing quote. Because what it said. What? Right there. Okay. I like the interactive aspect. I think that's a very revealing quote, because what it says is we need to, when we can explain it, we're explaining it away. It's noise, not signal. I don't have to worry about it, in a sense, because it doesn't fit in with our model of efficacy. Our model of efficacy implies a pathophysiological entity of some sort or process that the therapeutic intervention can maneuver one way or another. And this doesn't make any sense to me. And by saying, alas, he is saying, I can't think seriously about that. Maybe I'm being a little over-interpreting this, but I don't think so. I think it's like what a lot of us do instinctively, and in some ways there's a certain logic to it. It's like shining I use this analogy a lot in teaching, and it's like shining a flashlight in the basement, and he sees what he sees. And what he sees is a set of procedures that make no sense in terms of the therapeutic models, the therapeutic procedures that seem to be efficacious to him. So one thing I wanted to do today was to talk a little bit about how to think about efficacy and medical system, starting with traditional medicine circa 1800, 1850, and then talk about contemporary today system, what our system is. and maybe what a placebo is in our system. If you look at definitions of from medical dictionaries or read diaries of doctors or look at their ledgers from the early 19th century, it's clear that they didn't use the word placebo very much, but they had the concept. When they went to visit a patient, they not only carried a lancet to draw blood, but they usually carried bread pills or sugar pills. They were making a kind of triage. They were always making a prognostic triage and saying, when I see this patient, I have a set of choices. And some choices where I need to intervene, I'm going to bleed them or give them some mercury or whatever, salve or whatever seemed appropriate. But there's other cases, either because there's nothing we can do and the trajectory is downward and there's nothing to be done, or because they are not in no danger and it's better to just let them think they're being treated. So that to begin with, you have the idea of a placebo as resting on a distinction in the doctor's mind between efficacious and non-efficacious. And I think it's important that just because we don't have the same set of ideas about what was efficacious, we shouldn't forget about how important that distinction was, because that distinction gave the doctor a certain authority in his own mind as well as the patient's. That he, and I use he advisedly because doctors were he, even though people giving care were not necessarily he. It reassured him that he was in charge. And by reaching in to his doctor's bag and taking out the sugar pill or the bread pill instead of the lancet, he was in charge of that clinical interaction. And remember, a simple demographic point that 90% of people in the Anglo-American world lived in rural setting. We would consider rural settings in communities of less than 2,500, and mostly in much smaller communities. And they were not treated in institutional settings. They were treated in their own homes, so that the witnessing was a bedside witnessing with family members, and that the physician and the patient often knew each other, that there was the performance was a very personal kind of performance, and presumably had a certain psychic efficacy, whatever that might be. I want to keep the placebo effect issue as a black box. I'm not going to get into what was going on in the patient's head. I just want to describe the nature of the clinical encounter. Now, there's a problem with this, a tension. And I'm going to talk about some tensions in the system and then talk toward the end about tensions within our contemporary medicine that the placebo can help us think about. One tension is that they all knew that everybody knew and assumed that body and mind were interactive, and that stress, for example, they didn't use the word stress, but things that caused anxiety, emotional tension could have physical effects. No one ever doubted that. And there was a wonderful example that some of you may know about Elisha Perkins' metallic tractors. He was a Connecticut doctor who, in 1796, I guess it was, patented these wonderful metallic, they're like a little pointy, like a smaller version of a chopstick or something, only with mystical metals. And if you drag them along the body of somebody with especially chronic rheumatic symptoms or other, joint pain, that it would improve them. And these got very, very popular. In fact, in England, they sold for, I think, 5 guineas, which was a whole lot of money then. And there was some skepticism, and there's a very famous book by John Haygarth, who was an important English clinician who wrote about smallpox and other contemporary matters, but who did a clinical trial with a dummy tractor, which was made of wood and painted. And of course, he got wonderful results. And he wrote a sort of a pamphlet, which the title of which is Of the Imagination as a Cause and as a Cure of Disorders of the Body, exemplified by fictitious tractors. But no one questioned that imagination wasn't a thing and that it wasn't physiologically powerful. And the word suggestion was used in the same kind of context. So the problem, in a sense, was that he thought he was attacking quackery, which he, in a sense, was. But they were also, in some sense, attacking the peculiar legitimacy of the medical profession. Because if imagination and suggestion were powerful actors in the healing process, well, then anybody could participate. And this tension, this internal tension, became increasingly visible and unavoidable by the middle of the century, especially, and this is true again in England and the United States, because of homeopathy, which became the most visible institutionalized rival of medicine, of organized standard medicine, mainstream medicine. And one of the aspects of homeopathy, as then understood, and as some of you may have studied the history of homeopathy, it was based on the idea of progressive dilutions of the active drug. Infinitesimals was the term that was used. And to any common sense person who didn't buy that particular ideology, it was clear that homeopathic medicines were placebos, but they didn't use that word very much. It's in medical dictionaries, but it wasn't used very much in the vernacular. And there's some wonderful quotes from doctors in the mid-century who said, well, you can't believe in homeopathy because if you believe in homeopathy, it's faith healing. Oliver Wendell Holmes has some wonderful quotes of this kind, who is a local worthy and an excellent prose stylist. But of course, there's a tension built in. And Holmes and some of his contemporaries were smart enough to say, if this is in fact true, we can't be faith healers. We have to devote ourselves to rational scientific medicine that distinguishes us from faith healing. And he was not the only person to say it. And I think one can follow that trajectory through the 19th and into the 20th century with medicine becoming increasingly laboratory-oriented, the germ theory, with a certain kind of legitimacy built into the discoveries of the cause of key infectious diseases, with the acceptance, the gradual acceptance of the notion of specific diseases with specific mechanism that explained the pathogenesis and course of those diseases, which created a whole new kind of logic for therapeutic interventions. But nevertheless, if you read some of the guides to doctors or articles in the medical press, they complained, or not complained, but observed and/or complained that patients wanted prescriptions, and a lot of them, or some of them, would be happy with just advice and a visit, but some of them would not be happy without a prescription. And that's why you needed to carry around your sugar pills. This was, you might say, blaming the victim, but they weren't worried too much about ethical questions in our sense of, informed consent and deceit. What they were, the way it was understood, was as a way of, in a sense, distracting, but they used the word, earlier in the century they said amuse, which doesn't mean quite the same thing as it does now. But there's a kind of condescension built into the language, I guess, to make a complicated linguistic story short. In other words, again, it's a way of the physician writing for other physicians and saying, we know which cases are ones that really don't need our intervention, but they need, in terms of the pathobiology of a disease, but they need our intervention in terms of their own psychic needs. And often those patients were women. There's a gender issue here that comes up a lot. But also there is the notion of male hysterics too, of kinds of people who overreact to, couldn't just buck up and deal with their symptoms, and they wanted that intervention. So that there's the notion of what I call performance continues. We can't, obviously we can't document it with video, or we don't have the kind of data that an ethnographer might be able to record in some other culture, but I think there's a commonsensical logic to saying, oh, it made sense for them to do that kind of triage and keep doing it. I'd like to, I'm going to switch, I want to switch to a more modern period. I know this is abrupt and schematic, and I apologize for the, what's the word, auditory dysfunctions, but we all know that we live in a very different world with a very different healthcare system. Most of our care is not delivered in the bedside in someone's house. It's often delivered by a physician or nurse practitioner or someone who has never seen the patient before. It is often delivered in an institutional setting, though not necessarily, so that you might say the domestic drama, the stage is very different, but still patients get sick and they want reassurance, and so in some ways medicine is always medicine. But there are some peculiar tensions in our system that I think the placebo concept helps us think about. When I was thinking of titles for this talk, one of them was Thinking with Placebos. I couldn't say Listening to Placebos because that's been sort of used. And I think that it tells us some interesting things. And let me just list 3 areas of tension that concern with placebo will make you think about. And the first, and probably the most general, is the question of broadly idiosyncrasy, or I call it N of 1. In other words, we have a medical system in which reality is a collective scientific reality that is based on laboratory results, it's based on bureaucratic consensus, it's based on a whole set of things that are abstracted from the patient, like clinical guidelines, best practices, nosological categories, etc. Yet at the same time, the patient is still the patient. And I don't want to sound preachy, but there is a tension between medicine as a collective, abstracted body of knowledge and practice, and what happens to the individual patient, qua patient. And I think if you think about from whatever perspective you think about placebo effect, or try to explain it in whatever mechanisms you might hypothetically suggest, it doesn't escape that tension that is characteristic of our society. Another area that placebo effect makes us think about, where there is a tension in medicine, and that is mind-body issues. We don't do very well with them in the sense that we can't explain them very well. I mean, people have explained different pieces of mind-body relations, but we don't have a kind of consensus that we have about certain aspects of molecular medicine. And I think the mind-body thing is obviously a central issue for anyone who writes about placebo. But one point that I want to emphasize is that mind-body is also culture, context, body. That whatever the body is processing, when you experience something, it's not random. The body is historically conditioned. It's part of a culture. So when it's being treated, it is responding to a specific set of cultural cues, ideas about what is in fact happening. And in that sense, the body is porous. It's porous between culture, institutions, internal physiological, metabolic, neurochemical realities. And it's sort of a truism to say that, but it often makes students uncomfortable. As a longtime teacher, I've found that. And I think thinking about placebos makes it impossible to ignore that complex set of realities. Another area of tension within contemporary medicine is efficacy itself. In other words, how do you judge what's successful and what isn't? What are the parameters? And there's a growing feeling, I think I'm now speaking in a very contemporary frame, that maybe our normal, quote unquote, normal NIH disciplinary ways of judging efficacy in terms of randomized clinical trials, in terms of the whole apparatus of truth manufacture and legitimation, is inadequate. It's one piece of a more complicated medical system. And if there are, for example, in the contemporary healthcare debates, people have started talking about, should physicians be thinking about economic variables, both for their individual patient and for the system? So it brings up what I like to call the question of social efficacy. That in some sense you can't there's nothing wrong with judging efficacy in terms of randomized clinical trials and trying to get rid of the noise of placebos and figuring out how to structure your arms and recruit your patients. But on the other hand, that's only a piece of efficacy. And I think you need to, maybe I'm being a little preachy again, but I think we need to think in terms of social efficacy, in terms of this larger set of issues that impinge on the individual patient, the individual patient's body. And whether it's inequality, or whether it's climate, or whether it's any other set of factors, it makes you think about what is contingent, what is constructed. And I guess one of my ideological points, I guess I'd like to make, is that given our hierarchy of values, our meaning the world of the academy, the world of learned disciplines, the world of specialties, in a sense, the individual patient's experience is epiphenomenal, and what's real is the structure of ideas, findings, collective agreements, bureaucratic practices. And there's a kind of tension, I used the word tension before, built into that limited notion of efficacy. So I guess I'm being preachy about that way of thinking about what efficacy should include. And the other preachy part of it is, I guess, I've always felt that the medical profession, qua profession, this is preachy part, has this collective responsibility to think in these larger terms about the world in which they live, in which they move, in which they have moral responsibilities, and by implication, and historically, political responsibilities, I think. But, another point that I wanted to emphasize is, or give some examples, is how tricky defining placebo is in our world, too. Maybe it was tricky in 1800, and you say, well, is bleeding a placebo? It's sure not inert. But what about the most obvious example in our world of the tenacity of placebo effect is the use of antibiotics, which people have been warning about overuse and routine use. And, they're the sugar pills for a lot of physicians, and it's more complicated because a lot of physicians who prescribe antibiotics are aware of the problematic nature of those prescriptions. But maybe in a systemic sense, it serves as a placebo for the whole social system, because you're dealing with the worst case scenario you think. You're making the patient amused, to use an 1800 term, in the sense of feeling that the transaction, that is healing, has taken place, and the doctor has performed something only the doctor can do to help you heal. And I think today, one has to start thinking about our whole apparatus of screening, risk reduction, of a world in which many of our patients have no symptoms, and which demographically people are living longer and having more chronic disease, often of an complicated, not so specific or easily diagnosed sort. So is someone who's taking their statins, is that a placebo? Or is it a placebo in some larger cultural sense for the system, and not just for the patient and the doctor? And I think it's important to realize that the placebo thing, the more I think about it, the arrow goes up to the doctor and down to the patient. That a lot of times these effects work both ways. And one can think of many practices that were effective, and we look back and say, well, at best they were placebo. Like HRT, that was hormone replacement therapy that was so widely prescribed not so long ago. And all the debates that are now in our front pages of our newspapers about the downside and as opposed to the upside of PSA testing, of what kind of protocols there should be for mammograms, et cetera, et cetera. So we have our own set of practices that allay anxiety, that have a systemic logic. We don't call them placebos, but I think they function often for people, for groups, as placebos. And let me just end with a final reflection, which is this, I guess you might say, disciplinary observation. I'm a historian, and I think that history provides a good way of stepping back from particular realities and realizing how contingent they in fact are and how constructed they are. And one of the characteristics of our medical world and of our modern world is that we sometimes forget about how constructed it is. And it seems it gets a kind of zoning variance for cultural construction because we assume it's natural and right and sort of different somehow than the Zuni or the Noor or some other culture or other time or place. And so I guess I'm making an implicit argument here by comparing these two different times and trying to talk a little bit about how the systems work differently to make an argument for history as a useful tool. And I think I'm going to stop. And because I'm very curious to, this was a very difficult talk to think about. I casually said I'd do it, and then I didn't realize how elusive the powerful placebo was.
Well, this is actually quite good because this leaves us with plenty of times for question and discussions. And I'm as eager as Charles is to hear your perspectives on this. So we'll go ahead and start taking questions.
I'd like to go back to your, okay. You opened by talking about efficacy, and you actually, and we remained a theme throughout your talk, and you talked about changing notions of efficacy, changing criteria of efficacy. But it seems to me one important dimension for understanding the role of what we call placebos now in the 1800s and before was the notion that efficacy was about a larger field, that it was efficacious if it made the patient feel better. And that the distinction between feeling better and getting better was a distinction that itself came to dominate only in the middle, late 19th century. So that goes back to the whole mind-body question, that it was that the medical culture was a different culture in a very deep way.
Well, I have a couple of things I wanted to say. First is that I thought someone was going to say, well, the way you talk about about efficacy boils down to functionalism. You know, that you explain everything in terms of some logic that it's functional in terms of some other piece of it, and that's that. But you didn't ask that question, but I thought you were. I think the point about the distinction between feeling better and getting better is one that would not have been clear in 1800.
That's what I'm saying.
At all. I'm not repeating, yeah. And it's only very gradually. And it's a very interesting question because I don't know anyone who's ever used that as an analytic, entry point and said, I'm going to study this and read a lot of texts very carefully. It's, I think, in some ways associated with the kind of rationalization of clinical therapeutics, of randomized clinical trials,
right.
And of the whole apparatus of thinking critically about how do you disaggregate the effect of a particular drug from the natural course of a disease or process, from psychic whatever.
Yeah. Well, I have a related question. Maybe I can just add to it. So, to what extent, it seemed to me that the professional, what you call the rationalization of medicine in the 19th century, especially the second half of the 19th century, was very closely related to the market competition with homeopathy and other forms of treatment, and that distinction was a tool in that competition, became a tool in the distinction between feeling better and getting better.
That's an interesting point. I think that people of, let's say, Oliver Wendell Holmes' generation, the academic doctors, the elite doctors, I think they would have perceived it, but they wouldn't have labeled it quite the same way you did. Because they also all believed in the power of mind-body relations.
Right.
And they didn't use the word imagination the way Haygarth would have in 1800, but they did talk about suggestion.
Yeah.
There was a lot of discussion about the power of inducing mental states.
But from one point of view, suggestion would be a good thing. a useful tool, if you could, the power of suggestion was part of the legitimate part of the medical toolkit. But from another point of view, it becomes illegitimate.
Well, there is a lot written about the menace of suggestion. Dr. Calgary and the evil. So people have been concerned about this because and from different interpretive frameworks. I don't really have an answer. I mean, I don't know anyone who's specifically written on that particular.
I just surprised to find out the word placebo was found in the Bible on Psalm 116, verse 9, in the 4th century, translated by Jerome in the Vulgate version. They say placebo domino, mean I please the Lord. And if you put into a historical perspective, over the past almost like 2 millennium, the word didn't change much. Still, I feel good, I peace, I delighted. And from a historical perspective, it seems to me it involved with a belief and faith system, regardless whether I have faith, belief in this substance, or I believe in the person, the one who prescribed the placebo, the doctor or the physician. From the modern perspective, I still find that the same, belief and faith is still working. Although, from a medical perspective, we engage in, basically we just, have a more elucidation of the molecular mechanism, or we call it MOA, the mechanism of action of the drug we prescribe. But in the old day, the old doctors, the practitioners, they might, give you the placebo, but he himself is the placebo. He have a faith in the medicine. He give it to you. So if you look from the other end of the table, it's a placebo on the patient perspective and placebo on the doctor's perspective.
Well, I tried to make that point that I said the arrows point up and down, which that it affects the doctor too. But also, I think you have to be aware that physicians were performing authority when they made that decision of this patient needs intervention, this patient needs, quote, amusement, faith, whatever you want to call it. And that's why I used the terms performance and transaction.
Yeah.
And I think if you think of this as a social situation, the physician is the performer. He's there, his body, his aura, whatever, in terms of is providing reassurance. But it has to be embodied in a transaction, in a thing. And I think that continues on, the idea that the thing has an emotional aura that is attached to it, and the efficacy comes in some sense through that linkage of performance by an authority figure and the transaction, whether it's bleeding or whether it's a sugar pill. Anyway, that's.
Thank you.
I probably try to do too much too fast. Oh, this is louder? The gentleman in the back, is that louder or a question? Oh.
When you step out of the medical context, as you suggested, our bodies are porous and we we move through many different contexts. And I was just thinking, going back in history of indulgences, when, with the sale of indulgences, you somehow may have felt better when you, paid for your sin. Do you see any modern analogies to the sale of indulgences, or modern metaphors, or modern placebos out of the medical context?
Oh, you mean outside of the medical world?
Yeah, in our society today.
I think I better not answer this question. I've gotten stupider as I've gotten older, but not that stupid. Too hard.
Hi. I was thinking in your talk about, I mean, today, I guess medical professionals are regarded as the most trusted professionals in the world. I mean, they regularly top league tables of trustworthiness and so on. And a couple of sayings came to mind just during your talk that made me wonder, has this always been the case? I mean, so I was thinking about a couple of phrases: one doctor creates work for another, or the physician is the disease. And I was thinking, maybe because of this slogan, that the history of medicine is the history of the placebo effect, made me think, well, actually, how strong was the placebo effect? How ambivalent were patients about calling on a doctor? Because it seems to me it may have been they had less faith, or some of them, than perhaps we do today.
That's a good question, and I think traditionally the last couple of hundred years, I would say there's been a secular trend toward more authority, more faith in doctors in terms of their intellectual capacity and technical proficiency, if you want to put it that way. And certainly there's a lot of vernacular skepticism, criticism, jokes about doctors in the late 18th century. On the other hand, people seem still, even in those cases, have like their own doctor. So your doctor's an exception. Maybe your congressman is an exception too. Yeah, I mean, I think it was good to bring that point up, but because my model includes authority, faith as part of the package, and it obviously didn't always work that way, and there were class differences and ethnic differences, and but I think the fact that the great majority of medical care was in the home, and not in an institutional setting, where the doctor would be not only impersonal but drawn from a different social class, made a difference. But that's it.
I just have a question about the placebo and how it fits in with the changing explanation of illness, because there were times when, way back they thought there were the excess humors, and then in the late 19th century, the idea of electricity, and there's a finite amount of, energy, and then later on there's the germ theory, and I'm just wondering how placebo changed with this changing concept of illness.
Well, placebos are cunning little fellows, and I think that what I was trying to emphasize is that I was trying to stay away from you might say, the post-randomized clinical trials world where you're trying to turn noise into signal, which means explaining away the placebo effect. But the fact that there are different models of explanation I don't think it undercuts the emotional logic of what I was trying to say. And the reason that I brought up issues like statins or antibiotic is that they're in a different world. And I'm not saying people don't have, circulatory cardiovascular disease, and they don't have infections that cause certain symptoms that are caused by microorganisms. But some of these social relationships, I think, they're not exactly the same, and they're often filtered through notions about what the doctor is and what the institutions are in which the doctor functions. And I think you could argue that even a lot of imaging has a placebo effect, though I wouldn't push that in print.
Would you say that because of the earlier or traditional forms of medical therapeutics, that the conflict between the kinds of interventions that different physicians would bring would be greater, measurably more confrontational than changes in therapeutics today would be.
Say that again. I didn't catch
Yeah,
it.
I am curious to know how people made judgments about one intervention being better than another.
When people, do you mean a clinician?
No, I mean people who had an illness and were seeking out help.
Well, that's a good question, because even today, and in 1800 or 1850 or 1900, there were choices. You could be a vegetarian and a hydropath. You could be a believer in, I use the homeopathy example, or you could be a believer in some or other of the alternative medical approaches today. But there does seem to be, as you were implying, how do you decide which one it is you choose, or what are the variables? Again, that's tricky to answer, but I think that there certainly is a dominant, you might say, dominant ideology about health and disease, and a dominant group of practitioners who represent that way of thinking, and society supports them. And so even if there is some skepticism or some criticism, I think there is a kind of mainstream set of notions about medicine today.
Yeah, I was trying to get at whether there was a contrast between the climate in which those evaluations would be made today by people seeking help versus what would have happened 200, 300 years ago, when the climate was more determinant of what was accepted, and there was no independent stance that one could take.
You mean the climate, you mean just general cultural attitudes?
What I mean is that if a lot of clinicians believed in bleeding or something else and some particular theory of the humors, then that was going to dominate what was available to people. And there wasn't any framework for thinking about, does that work compared to something else that another group of physicians was offering.
Well,
and today we do have a little bit more of a framework for thinking about that.
Well, one of the arguments I made in this article of mine that David mentioned was that I didn't want to go into any details, but I argued that one reason the system worked was because in that world, the layman's ideas about disease and doctors were mutually intelligible, so that when you bled someone, they understood why you were, it made sense. And doctors bled their own children. It wasn't, this was, so that there was a kind of cultural coherence, and part of the effectiveness or the efficacy of the system was that mutually coherent or mutually understandable world of how you got sick, what the body was like, and how you could intervene in it. And I think that world of, that kind of efficacy probably isn't true anymore. And I called that article "Therapeutic Revolution" because I thought there had been a revolution, but the revolution, in my sense, was not just antibiotics but also a world in which you didn't have this shared knowledge and shared sense of what the doctor was doing and what was happening in your body, but that there was a different set of reassurances you took things on faith. You could take a pill and the doctor, well, maybe diuretics are. There are examples where you associate taking a particular drug with a certain outcome, let's say. But mostly, you accept the technical skills, the technical understanding of the physician. And so when I gave it that therapeutic revolution title, I was thinking in, I guess you might call them ethnographic or, cosmological terms, that the relationship between ideas and patients and doctors had changed dramatically. And it's also dramatically in terms of institutional settings and technology, and it's.
So Charles, do you find this current era, the most current era, with people looking up their diseases and the latest treatments on the internet, and now that there's very widespread internet, perhaps a return to an earlier kind of relationship, or still a different, have we seen a change from the therapeutic revolution that was more typical, say, 25, 30 years ago?
Can you hear me? I think that's a very interesting question, and it's a number of people have asked me the versions of that question, and physicians, some of my best friends are doctors, and they jokingly complain about patients coming in with their own, vacuumed up set of information from the internet, and I think it probably does have an effect. But I think it's still at the margins. But I'm not an expert on media. But there's another, mirror image, if you want to call it that, is I've counted about half dozen friends who said to me, I was at the doctor's and they were not looking at me but looking at the screen, because you've become an epiphenomenon. And that's one reason I said that. I mean, I'm not making this up. Real data. At least casual, episodic, anecdotal. Yeah, make that.
So the placebo concept has been always a boundary concept, so to say. So in the view of Shapiro, for example, it is a boundary to divide exactly when medicine became scientific, so to say. In randomized clinical trials is a way of making and drawing a boundary between efficacy and molecules, basically, effective compounds, and ineffective ones, or non-specific effect. So, and also it is a way to draw a boundary between what is subjective and objective, often. You spoke a lot about tensions, so 3 tensions, and also of the role of placebos in clinical settings. But there is also another story, and my question is about that story, that is to say placebos as diagnostic tools used by physicians, precisely to distinguish, perhaps, the feeling better from the getting better, because, of course, medicine may not work for everybody. So my question is about that. What's the role of placebo as diagnostic tool within the therapeutic relationship?
That's a very good question. And I don't know enough about, as this is an actual clinical practice. So I think so I'm not going to answer that, but I did want to emphasize that the boundary question, because I wrote out this lecture, but I didn't like to read lectures, so it just. But I did in my original draft talk about boundary questions, and that's when I said that placebos are good to think with, because boundary setting is always good to think with, and when I was thinking of titles, one of them, as I think I may have said, was placebo, efficacy of placebo, noise or signal. And I think that it's been important to try to set a boundary between, you can dismiss the placebo effect and in fact anything you can't measure or manage in terms of your world if you're a scientist or a clinician investigator or whatever, and say that's noise. And what you do is you've tried to, in terms of a lot of the writing about placebo is about how you tame it, other it. You make it other, and you take it out of your system. So I didn't go into enough detail on that.
I'd like to follow up on just that question. By the way, I thought it was a fabulous argument, and it made an anthropologist very happy. Put it that way. But you said when you started your account of the earlier moment that the critics who begin to try and expose the placebo effect are actually critics, right? That they cast a certain light on the actually existing system of which they speak, right?
I'm sorry, I didn't hear
those who wrote first about the way placebos operated under more traditional settings were in fact critics of the system. That in talking about the placebo, they were actually revealing the way in which the system and the physician themselves used the placebo in a way to draw boundaries and to insulate the practice of the profession at that time in certain sorts of ways. And then when you move to the contemporary situation, you talked in very interestingly expansive ways about how the placebo could be seen to be a kind of a placebo for the system itself that we operate within, right? And that one had to think about it in those terms, in terms of the kinds of limits that we place on ourselves if we don't think about social efficacy. And you seem to imply that there was a way of thinking about where the placebo operates in our contemporary system that could be used as a critique for prizing open some of those issues. Questions of inequality, questions of the way that medicine functions, the way in which the placebo is often a kind of promissory note for where medicine draws the line. It cannot go further. It can't deal with certain kinds of issues, maybe issues of a more social or systemic kind. So I just wondered if you wanted to say something more about that, because it seemed to me that that's precisely, I mean, the kinds of domains. I would say, for instance, that the ways in which we use chemotherapy even in many contexts in contemporary medicine operates as a kind of placebo, as a statement of the limits where we'd like to be able to go but we can't, as a statement of concern, and so on. But that also raises all kinds of other questions about where resources should go, what hard decisions have to be taken, about the less palatable sides of what we don't do when we give placebos.
Well, that's not actually a question. But no, you were elaborating something that I probably should have said more about. And that is, but the one thing that I guess, I don't know whether I said it in those words, but I think one thing that fascinated me about the placebo, it also made it hard to think about, but it's good to think with, in the sense that because it's liminal, because it's a boundary issue, because it incorporates values and practice and orientations, it's a tool for thinking about those larger questions that you were implying. And maybe I should have elaborated that more. It is something I probably, if I write this up, I couldn't decide whether I should write it or not. So you're my focus group. That's something that I would expand. And I think that the issue of thinking about chemotherapy, screening, risk reduction, and thinking of them as placebos would not make everybody happy. And so I'd have to write it in a very careful way.
Thank you, sir, for a very interesting discussion. I wondered, how do you anticipate the placebo effect that historically has depended on a patient-doctor relationship varying as we go into an era
You know, that's an interesting question, and I think ordinary people like to think that there is a person with a cognitive and moral gyroscope up in their head that is relating to you as a person. When in fact, in a lot of institutional settings, you're dealing with a group of people and a shared, that struck me. I was writing something about diagnosis some years ago, and it struck me how people want to think of diagnosis as an event, when actually it's often a process, and it's a process that's staged, and and yet I think the patient wants someone who's a person to come in at that moment. That's your diagnosis. So it has a kind of, I used the word performative before, but people expect that, and expect it to be in the form of someone who has a unified relationship to them. And so maybe there is some need that isn't being met, and people talk about this who are critical of the healthcare system.
So I missed some of the talk, so if this was covered, but there's a word I haven't heard in the discussion, which is deception.
Deception.
Deception. So, one aspect of placebo treatment is as a physician deliberately deceiving a patient knowingly. Now, when both believe something's working and they're both deceiving themselves, that's a different situation. But I think the common one that at least I witnessed in my training was saying, this patient is a crock, and we're going to, in quotes, and or a hypochondriac or psychosomatic, all these labels that I think are pejorative to patients, in my opinion, and probably do a certain amount of harm to stigmatize patients. So there's an element of deception where we're going to, so on one hand you can say, well, this is harmless and we're just going to give them their better, and then you have that previous question, it's a diagnostic trial, that proves the patient is a crock, they get better, which actually is a very unscientific way to think. But what does it mean to sort of introduce this element of deception in the physician-patient relationship? We just heard that alluded to that committees are undermining their relationship, but this is sort of a deliberate risk of poisoning that relationship, especially because I don't think we talked about what happens when the patient finds out, which they must in some situations, right? Some of them go merrily on their way and feel better, but other ones maybe at some point find out what's actually that they've been given this hoax, this sugar pill, and how does that play out?
I was trying to avoid these because these issues sometimes get phrased in ethical terms about patients' right to both not only informed consent but understanding of what their choices are, and the notion. It's interesting. One of the things I did in preparing for this is I read about 30 medical dictionaries. Not read. I looked up placebo. I don't want to claim, heavy-duty research, but starting about the middle of the 19th century, the word humor comes in. Humor the patient. It doesn't come in before that. And then I think it's the Wikipedia entry. The Wikipedia uses the phrase designed to deceive the patient. And the OED talks about a measure designed merely to humor or placate someone. Now there's a spectrum. It's just like a spectrum disorder here. From a deliberate, self-conscious, this person's your crock example, and where you are dismissing in a condescending way the dignity of another person, which can have economic or non-economic aspects. But then there are a lot of more complicated questions. For example, if someone is moribund, if they're in hospice, sometimes, and their family is demanding you'll prescribe something that you know is not efficacious, well, you're, quote, humoring them, but maybe the moral burden isn't exactly the same. So I think you bring up a very complicated set of questions. And there were it's interesting that this is not research I've done recently, so I'm depending on my memory, but there were medical society debates in the late 19th into the early 20th century about the ethics of prescribing inert materials. In other words, is it swindling the patient? And there were some medical societies that passed, you might say ordinances where they agreed that this was not proper. So this is something that they began to think about, and I think partially because up until the 1920s, medicine was a pretty competitive field, and you didn't want to steal patients from another doctor, but you always had to be worried that patients would be stolen from you, and there were ethical questions about exploiting patients or not exploiting them. So the economic world was pretty different. Yeah. There's a bunch of...
I got one. Charles, thank you. I learned a lot from your talk, and it actually provoked me in a lot of ways. One thing I want to say that I learned, but I want to make sure I learned the correct lesson. On this, I never thought of the question of the social placebo as a society-wide thing. And on this side of the river, doctors, physicians talk about numbers needed to treat. Penicillin for infections, like 2 patients get a benefit. 1 patient gets a benefit every time 2 patients are treated. But for something like hypertension drugs or statin drugs, you have to administer several hundred patients to prevent a cardiovascular incident. So the numbers needed to treat might be 300 to 1, 400 to 1. And I'm thinking about my father when he would take his antihypertension medicine exactly at 9 in the morning, exactly at 2 in the afternoon, and exactly at 7 in the evening. And in fact, there was only 1 in 499 chances that medicine was actually going to help him prevent an incident of cardiovascular disease. But in terms of society-wide, it was obviously going to prevent many, many cases. And in fact, my father, I would interpret as being involved in a ritual that had society-wide consequences, but for him individually, it's unlikely, probabilistically, that he had an effect from that medication. I want to know, did I draw a proper inference from what you were saying to my story?
Well, I never met your father, but he seems very, he seems very compliant. So it probably worked better for him. The thing that as I was thinking about this, I think this whole notion that I was kicking around about structural placebos, in terms of the system, is something that I sort of started thinking about and haven't sort of gotten to the end of yet. But I think it's very important in our system that it something that, as you point out, has a rational aggregate statistical logic. But and even if you can't pinpoint a particular person, but in terms of system maintenance, and I think system maintenance is a really important concept here. Getting people to think like your father, and getting doctors to think that prescribing for your father is the right thing. Well, is that a placebo, or is it an objective public health intervention? Now, it's both. I think it'd be hard to put. I want to get this straight in my mind, but it's interesting that you asked that question. Yeah, there's some.
Well, that gets to the whole question of statistics, which. Looking at the screen instead of the patient is somewhat the same sort of thing, where you're really thinking statistically rather than individually. And having gone to medical school in the era where the physical exam was a very important component, I've talked to colleagues who graduated 60 years ago, and they're just very impressed with the difference, and I think some of them would rather that the physician look at the screen and think statistically than to kind of give what might have been called bedside manner in another era.
Well, you're not the only person who's, who's made, I mean, I've heard a number of physicians who've trained, in the pre-high-tech, prehistoric, yeah. Well, it applies to me, though, but that's why I use what it seems to me the irony that the actual patient is an epiphenomenon. And I think that's a very powerful way to think about it. That the real reality is abstracted, aggregate, statistical, molecular, you put together a particular picture for a particular condition, patient. And in some sense, the patient is an epiphenomenon. It's a random anecdotal reality, but for the patient, it's not a random anecdotal. It's his life or her life.
It happened in.
Well, when belief and statistics are two words that have complicated relationships.
It's interesting in Boston. There's a historical fun case about placebo. Remember 2003, the company, they get FDA approved for the drug for non-small cell lung cancer, Efficacy. And then it hung around on the market for 2 years. And then by the year 2005, the FDA withdrawn that drug from the market because they don't show any clinical efficacy. And then I met the patient at the Boston Medical Center, which is not my patient, someone else's patient. And she told me, well, I like this drug. I really like it. I love this drug. So, but I told her, oh no, wait, look, watch the newspaper, all the TV, all the journal, they said this drug, Efficacy, had no clinical efficacy. So you are taking almost a placebo. But this patient is in the terminal stage of her illness of non-small cell lung cancer. And then I do not push because of this scientific reality. But I say, okay, you like it, keep it.
Well,
make it feel good. So why not?
Yeah, well, that was one of the examples that I was, using as
about the changing view that the patient is an epiphenomenon, I think it's important to distinguish between the individual and the statistical comment, and the personal human interaction between the physician and the patient, and the quantitative mechanical interaction. So there's a big push now for personalized genomic medicine, which is not about statistics. It's we need to know your genome sequence in order to give you the proper medical inference, but you're still, the patient as a person is still an epiphenomenon.
But I think for a lot of physicians there is this tension in their own minds, and one way of solving the difference between the aggregate is ultimately there'll be genetic medicine and it will be personal medicine, and you won't have that.
But you still have the isolation and reduction of the patient to the numbers and the sequence.
But it'll make the doctor happier. and better outcomes, presumably. You've had your hand up a really long time. Yeah. Only you don't have you could have a low-tech solution. You could.
I don't know if I need this mic or if that's a placebo, but okay. So as a graduate student in history of medicine, this idea of a placebo as a larger effect kind of is blowing my mind pretty well, and especially breaking down the barrier, I guess we're going to say the barrier separating the sort of idea of a placebo in a clinical sense versus the social sense sounds great. But before I get myself wrapped up into this, diving into a Foucault's rabbit hole here of who holds the information.
I'm not in this rabbit hole.
No. I meant me. No. You're. Oh, obviously, no. I'm just an egg. So, like, what dangers do you see in your thinking about this so far, of how far this idea of placebos can be expanded out? Where are the roadblocks that we should, if we want to keep thinking about this, that we should be aware of, or things that have come up that you would caution, say, on somebody new like myself, in thinking about this in broader terms?
I mean, I don't have an answer of a simple sort, but I always believe that the more self-conscious you can be, the better off you are, and that it seems to me that thinking about how complicated these issues are and how they have personal and social dimensions is a positive thing. So that I know that sounds like a cliche, but I think we need more of it, and we need to think more about some of the dilemmas of this, quote, going the N of one problem. I mean, for example, recently, over the last 5 years, oh, can you hear me now? Sorry, I was waving my arms around. This is going to be the last question, okay? There have been a series of consensus reports about, let's say, mammograms. You know, should the normal protocol, no family history, should it be starting at 40, starting at 50, should be every, it changes. And then, but one of the things that doesn't change is women who say, no one's going to take my mammogram away from me because my sister's life was saved because she, had her disease process was intervened in because of that technology. So the people always personalize, and you can't blame them because we've, I think, in some ways oversold some of the efficacy of these screening procedures, and but I think the more you can stand back from it and educate people about the intractability of some of these questions, we're better off. But that's not a counsel of perfection. So anyway, thank you very much.